scaling up our original ELP-QUIP project, and I think I've also referenced the Danish study about perforated peptic ulcers. So we're trying to use what we think is the best evidence from the EPOC, from the Danish study, from ELP-QUIP to actually put a good care bundle. And we'll coach you all sorts of things like leadership, QI methodology, statistics, how to make your run charts throughout the course of the next 6, 12 and 24 months eventually. Let's see what we've got. So this is we've been talking about this for the last 6 months of the group. What we don't want you to do, is give you a massive amount of new work to do. And in particular, we don't want you to collect more data unless it's very focused and very specific. Okay? So who here has actually downloaded some Nial data and got a run chart out of it? Yeah. Okay, so Nial is an amazing thing, but you do actually have to get the data out of the black box. Because if you don't know how you're performing, 22% mortality rate in Guildford, you're never going to improve. So step one, which we'll talk about a bit later, is going to be getting your Nial data, and we've made it nice and easy for you. Okay, so this is, we've tried to base this as much on the original ELP-QUIP care bundle, but using the Nial database. And at times, we're going to ask you to collect a bit more data, especially about sepsis. And at times, we're going to use this based on Nial data. Okay? So what I'm going to do for the next 20 minutes is just run through each one of these steps, and then we've got plenty of time to discuss what we want to do afterwards. Just to read them out to you. So it's basically, Nial doesn't do early warning score, it does lactate. So we're going to use that as a form of risk assessment. We're going to talk about sepsis, we're going to talk about getting people to theatre quickly, risk analysed, goal-directed, when people go to IT, and as Carol said, she wouldn't let me do care bundle 6 and 7, but it's get consultant. Okay, so the first one is the first step is identifying sick people, and it's Nial question 3.5. Now, so we had a bit of an argument about whether we should use P-possum as a risk assessment, but the difference about P-possum, it gives you a number, what's the risk of death of this patient. But we wanted something that actually motivates you to do something. So most hospitals have got a scoring system like early warning score or Muse, which then prompts a response. So if you've got a raised early warning score, you get outreach, or someone comes along, they'll probably do a lactate, we're good at that in this country, and then they'll start resuscitation. And there's a whole load of pathways follow on from that, so there may be a sepsis assessment. The use of early warning score lactate as part of the original ELP-QUIP pathway, it's part of the Danish study, and it's part of EPOC. As I said, most hospitals will have an early warning score lactate-based escalation policy in place already, and it's also based on the NICE 50 guideline. Point out that P-possum does not make you do anything. It gives you a number and you say, well, this is a fixed number. But what we'll do is reduce that risk to people by escalating them and resuscitating them. So that's what it's based on. These are the, I think, 2, 3, 4, about 10 hospitals that supplied their Nial data to us so far. And this is just looking at lactate, because that's the one that's measured at the moment. Okay? So you see there's quite a discrepancy between some hospitals do 30% lactate, and some people are up to 85%. So we want people to think about identifying sick people with lactates, and then get them into that escalation pathway. So someone's going to say, how the hell do you do that? Okay, so the diagram of a driver diagram, but there's a systematic way to go to your hospitals and look at that in a sensible fashion. I hope I'm in the wrong place. Okay, so the next thing is about sepsis, and as Carol mentioned, there's almost nothing on the Nial database about sepsis. There is one question which you can work out what percentage of people get antibiotics before they come to theatre. But it doesn't say if it's the right patients and how quickly they're getting the antibiotics, or if they're getting the right antibiotics. So as a group, we're going to have to do a bit of local auditing about how well we treat sepsis or not. Again, giving antibiotics is like, everyone recommends giving antibiotics, why wouldn't you? We may need to do some spot audits and local collaboration. The slight tricky thing is that I know for certain that the new definitions for sepsis are coming out on the 16th of February. I think I'll be part of that. So we just need to keep that in mind about how we're going to define sepsis. It's going to change halfway through this project. And the January collaborative will focus strongly on sepsis. We're not going to do everything at the first stage here. It's not going to be change the world tomorrow. We're going to do this in a stepwise fashion. So we'll help you through that. So I've put this slide up already for you, identifying the reasons why we want to give antibiotics and drain the pus if we can. And this one I think you've seen already as well. Leading cause of death is sepsis in the over 80-year-olds. And this paper from Carol and Tim and a few other people in the audience from Bath, looking at their data recently, saying that infectious causes are the leading cause of complications for not far behind by pulmonary complications. So sepsis is big up there in causing complications after motor laparotomy. I just pulled out some of the data from the Nial document, which I've read in detail now. It's a good document actually. Not surprising. So I think, if I'm not mistaken, what they did in the Nial is they looked at people who had a diagnosis of peritonitis from a surgical finding. So it wasn't a SIRS defined definition of sepsis, it was peritonitis at surgery. So whether that's the right thing to measure, but it said that half be waited for more than 4 hours and a quarter waited for 7 hours. You'll find to have peritonitis. We're not doing things well there, are we? So I think there's lots we can do to improve on that. I just put this slide up because this is recommendations from Nial, and you can read them if you fancy. So review the pathways, robust mechanisms in place to identify patients with sepsis, and regularly audit data. The point is that us, or you, or us as a group, the multidisciplinary teams we're setting up, are ideally placed to affect change in sepsis, okay? It's not someone else's, it's not manager's job to do it, it's our job to do it, okay? So we have to take ownership of this and sort out sepsis. This is the Elquick slide which I showed you earlier. These guys really cracked it, okay? They got involved in the A&E departments, they trained the junior doctors, there's lots of coffee and donuts being handed out, I presume. These guys, which is Guildford, did very badly. I was ashamed of that. I've done something like that since then. So I'll take that bit out. Nial still under play. The Nial database is not good about sepsis, and we can actually add some data fields, I think, Tim tells me, to the Nial, so we might just think about that a bit later. Many A&E departments at EAUs are currently following the national sequin for sepsis, so we've got, that's on our side. So hopefully people are putting together pathways in your hospitals which are being adhered to and measured and audited, which is good. I know KSS and Wessex HSMs have got sepsis collaboratives going on. I'm not sure about West of England. So all three HSMs have got sepsis collaboratives going on at the moment. And I think they're probably all looking, if they've got any sense, be looking at that sequin focus in the front of the hospital. Django said a bit about already, and I think this, as Carol said before, this could be a major area of improvement for us. Okay. So this is the 10 hospitals that submitted their data. I think these were people, you have to help me out here, thanks. I think these are people who had the diagnosis of peritonitis. We're doing quite well. I think we need some more local data about that. 60% of people. We need to up that a little bit. Okay. So next thing is about getting people to theatre quickly. And as Bruce has pointed out earlier, there are, in the original output project, we just basically lumped everyone together, and we found this quite difficult not to crack. But I think Nial has definitely done us a favour about separating the patients into category 1, i.e. within 2 hours, category 2A, which is 6 hours, and then all the rest, which is 2A3, which is 6 to 18 hours. So the macro, which you're going to be using to look at your Nial data, will report those 3 categories, I think. Yeah, so you have the 3 categories, so it'll do it automatically for you, so you have your time for each of those groups. Okay, if you want to look at the booklet Nial data, it's timing for question 4.1 minus 2.2. You'll get the data stratified by urgency. Those are the standards. It's recommended by everyone. And the evidence lies in the sepsis slide, which I just showed you earlier. So this is the key standards from Nial. I've stolen shamelessly, which is good. We'll help you sort of sort out how you get people to theatre this quickly and think through your process, your system, to come to some sort of clarification where you can expend your efforts. So you need to basically match the theatre access and those people given priority. They record it, which is done on the Nial database quite well. And Carol, I suspect, wrote this line: delays in surgery, if they are surgery, poor outcomes. And we need to audit them. We've realised they've got very high mortality. These people should be taken to theatre quickly. And I would love to have a conversation with some surgeons one day about the sense of not operating on people and leaving them on the ward for 48 hours and not getting their cardiac medication and ETs. But that's another discussion. So this is the Nial data. In fact, they reckon that most hospitals are doing pretty well, but they pointed out that for the most urgent cases, only 77% of people get to theatre in a lot of time. So we will focus undoubtedly on that. That's about, I think, and there's no interest in no substantial variation observed by time or day for the hospital, which is good. I think this is our local data, and hopefully eventually we'll get all your data put in, and we want to give you sort of a spread type sheet of how well you or not or you are doing. So this is for the 2-hour spread. So this is the time to get to theatre. So one hospital is on average getting people with immediate category 1 in 8 hours. Now either they're entering their data wrong or they've got a problem. Conversely, other hospitals are doing most of their people category 1 getting to theatre quite quickly. So what we need to do is get this hospital here and this hospital here and have a discussion about how they did it. And that's what collaborative is all about. Okay, so when you see those big variations, either you question the data or there's a difference in process, and that's where we can really start helping. Okay? This is for the less urgent, so 2A, 2 to 6 hours. Most people are getting them done, but there's a couple of laggards here, and we'll find out who those are and punish them later. So goal directed. Well, Maurizio here he's ready for your buns and arguments. So we're going to have a good discussion about goal directed later. But I think it's important to recognise that goal directed type fluid therapy has been recommended at EPOC, ELCRIC, and the Danish study, and 2 of those showed a pretty positive signal about improvement outcomes between 30 and 40%. So I think personally that there is significant evidence available. If you look at those papers in CARE, which I've done a lot in the last 6 months, and there's certainly no harm. And these are high-risk people with significant fluid shifts. And that's question 4.4 on the Nial database. There's some sensible things. This is just a summary from Nial again. If you look at some of the patients here, if you require immediate, so overall 52%, those requiring immediate surgery got 60%. So obviously someone's engaging their brain a bit here, but they're not engaging their brain here, are they? So we know these people got 25% mortality risk rather than 15%, and they're not really doing much better. So I think it's education as much as anything about who are the appropriate people to get this sort of technology. And I've put this slide up already, of course optimising a negative study, because at 30 days there's no difference, but at 120 days there's quite a difference, and I think I'm which group I'm going to be in. I have my laparotomy. In your packs, now you've got quite a wodge of packs there. You try not to be too inflammatory with what we've included in there. There's quite a nice review here by the Laparotomy Fluid Therapy Group, and hopefully they haven't got too many access to grind, but I think they make a couple of interesting statements about perioperative fluid therapy. They say there's 3 inescapable conclusions. 1, overhydration is bad. underhydration flag, and we assume, and what we assume about fluid status of our patients may be incorrect. I think that's pretty fair to say, that we are picking up fingers sometimes and hoping for the best. And I think, again, I don't think anyone argues with this, is that dynamic indices have been repeatedly shown to be more accurate, to accurately reflect fluid responsiveness, do so better than commonly used static hemodynamic variables such as CVP. Okay? And that they also recommend that periodic fluid should be individualised. And I think that's the great benefit of those types of technology. A number of times I've walked in with training and they sort of think they're fine. You give them a litre of fluid over a period of time and the cardiac output is doubled, as is their option. So I think it's the individualisation is important. Which technology you use, you can go and argue it out the back with the guys out there. But I do think there's a story to be told there. And we'll have more of that a bit later. So this is goal directed across the patch of the hospitals we've got data for so far. So some people have measured 25%. I don't know how they choose. Maybe it's just individual preference. And some people are up to this 95%. So there's a big variation there. And hopefully we'll continue that discussion later this afternoon. So last thing is, not quite last, is going to ITU. So there's a bit of contention here, and I think it's your fault, Kel. So about who should go to ITU. So originally I think people were saying, well, if you've got a 10% mortality rate, you should go to ITU. And they've come down to 5%. And then Mike broke up last week and was saying, well, maybe it's 2%. So let's just think about ITU admission a bit. And this is from Pierce's original 2006 study. It showed that if you go to ITU, you've got a low mortality rate than if you go to ward. So we've got to do something like that, haven't we? Pretty high mortality rates, by the way, 25 and 35%. Not that long ago. These are the key standards from Nial. Assessment of mortality risk will be made explicitly against each patient recorded. It should be shared decision making. This is just, I hope you can see that at the back. Can you see it? Some of the data there. So these are the risks. These are the risks here, the frequency and the percentage of people get to ITU. So if you've got a risk of 5 to 10%, you're about just over 50-50 chance of getting to ITU. And if you don't bother to measure the risk, so you ignore what's out there, and this is like just some of the water, you've got a much lower chance of getting to ITU, although as Carol's pointed out, they've got quite high mortality risks. So you do need to start having discussions with your intensivists about what are the true risks of people. When we did in Guildford, I just said, look, these people have got 22% mortality rate. So who in your intensive care has got mortality risk of that? There's very few people in intensive care. We have about 50% of our patients are post-op surgical cases in Guildford, and there's very few elective surgical cases getting anywhere near that. So P. Possum educates the risk for consent, I think, but actually the discussion about who goes to ITU should be, emergency body cavity surgery has got to go to ITU really. I think if we had the resources, they probably would. Carol's done the slide for me already. Who would not admit a bypass grafts or cardiac case to ITU? Who would start with esophagectomy and send them to the ward? What would the coroner say about that one? Whipple's 2 to 3% mortality rate. Well, you would not do it without ITU bed, would you? On HDU, free flaps, their mortality rate is very low, I think. Craniotomy. And I think I think we allow ourselves to get to a point of happiness where we say, well, we don't know the risk, so we won't send them to the ward. I don't think that's acceptable anymore. And as I said, Mike Grocott pretty much said 2% afraid last week. So, that's that. So this is our data across the patch so far. So some hospitals are getting about 85%. Why have we got 120%? Tim? You've got 120%? Lays in for the slides. Okay, so but some hospitals are getting sort of 90%. Some people are down at 30%. That's a bit of a worry, isn't it? So we need to think about that and discuss where they're going. Are they just ignoring it? Who have they got the sicker in their ITUs than this group of people? But interesting discussions happening. So consultant involvement. The Nial recommendations, which show that every more than 5% a consultant surgeon, and it's input by a consultant anaesthetist and consultant surgeon, and more than 10% under direct supervision by consultant anaesthetist and surgeon. So you let your trainers go and do your esophagectomy, which you will, of course. So I'm not sure about those, but it sort of makes a point, doesn't it? So this is from Nial again. If I could just work my way through this slowly. So this is the risk here, and so this is the percentage of patients with both consultant present, surgeon, anaesthetist, and neither. So, well, there's an improvement as you get sicker, which is good. There's an improvement in consultant input, and if you don't bother to document it, it's very poorly down to the lowest risk. So we're deceiving ourselves just on that fact alone. So, and if you've got the highest risks, there's still some people having laparotomies without surgeon or anaesthetist involved, high risk, not very clever. I think the next slide is slightly more worrying, and I hope, well, Mr. Hunter's probably seen this, unfortunately. So this is the time of surgery by weekday and weekend, and look at the involvement. So if you're looking through normal working times, you're getting 75% of the time you're getting both consultant surgeon and anaesthetist, and a bit more for either of them. During the weekdays, as you drop out, in the evening it drops down, and between midnight and 8, it's halved. Now, if you're going to take someone to theatre for laparotomy night, it's got to be something wrong with the patient, hasn't there? And that's not really good. And my point is that let's discuss the mortality of these patients with our consultants on call. I think they do, and then, if it comes to it, we need to rearrange their job plans. But I think the time has come to actually sort this out. And at weekends, I'm afraid it's worse. I think, so you're less likely during the working day to get a consultant surgeon and anaesthetist, and it's still pretty grim out of hours. Okay. So those are not good figures, really. And I think that, I'm afraid the anaesthetists are not as engaged as the surgeons, which is what we found out with the hospitals. So we do actually need to have a discussion with our colleagues. There we are, that's the up quick stuff. Some people got their colleagues involved. These guys changed their process, I think. Some were less convincing. And the surgeons in 3 hospitals got good buy-in and less so in others. And I think it's actually up to us in this room to front up to every week or two and say, so here's a patient, and they didn't do very well, so where were you guys? And our anaesthetic colleagues, you have to have some different discussions, but you have to have ownership of these cases. And rather interesting, this paper is quoted from Nial, and they said that from acute medicine, it's work patterns rather than just the numbers on call consultant makes a difference. So you can reduce mortality rate by freeing consultants from fixed commitments, like operating lists, just going to do the emergency stuff, where they had runs of consecutive work, so continuity of care, and when there's ward rounds and handover. So that's from our medical colleagues, we should learn it in surgical anaesthetics. So this is the local data, quite a variation again, 50 to 100% for anaesthetic input. And surgeons less variable, but running about 85%, which is better, but there's still some room for improvement in a couple of places. So that's the pathway. We're going to have a good old argument about that in a minute, I think. So what's our vision then? So the first thing we want to do is understand our morbidity and mortality associated with emergency surgery. And by using our Nial data, we're going to hopefully tell each hospital, allow you to understand your own performance on those 6 or 7 key metrics. Our job is to try and convert our original Upquick style project into a larger collaborative across 30 or 35 trusts, which should be an interesting, I've got any hair in my head by the end of that. We don't want you to have to gather loads more data. We want you to use your existing Nial data to change the way your systems work. We will do spot audits, or encourage you to do them, particularly around sepsis, but that will come slightly later. We want participants to develop quality improvement capabilities. So at your local AHSM meetings, there's going to be a lot at the front about the basics of quality improvement, what a run chart shows you, what a driver diagram shows you, how you can use those to understand your process. As those progress on, we want you to develop the ability to use those tools to describe what you're doing and make the changes around your own trusts. And we want to learn from each other. I'll show up in a minute. We've been through that one already. This is the team milestones, which I think is in your pack as well. It just talks through what you're going to be doing over the next 12 to 18 months, I think. I'm not quite sure. The local meetings in November are well planned, and there's going to be a lot of quality improvement education, and then get you to use your own data to understand. And there's also going to be quite a lot about leadership and change management. I think everyone enters. One of the things that I think Carol sort of touched upon was about getting accurate Nial data in. So we want people to think about who's entering the data and how complete that is. We're going to get each trust to extract that Nial data every 3 months. We've got a run chart maker. You've got on the website, tells you where to send it to if you don't know that already. I think Peter's telephone was on there as well to help you do that. And so we're going to do this, discuss run charts and plan appropriate interventions. Those are some other resources which we've mentioned already. This is our mortality rate across the patch. It's crude, but some big variations on there. 14, 16%, 6%. Now that may just be it's not risk adjusted, but that's a 100% difference in mortality rate, and we can learn from each other massively, I think. This is a statement about quality improvement I came across about a year or two ago, and it's brilliant. Every system is perfectly designed to get the results it gets. The only way to get real change is to change the system, and to do this you need will, ideas and execution. So if you think of Rupert Pierce's 15% mortality rate, that's not a great system. And the system that produces a 41% mortality rate in Carol's ELM, or the 45% for the 80-year-olds, is not a great system, I put to you. We're hopefully going to develop a will in you today that you're going to do something about this. We're going to give you some ideas how to do it, and then we're going to help you with the execution as well.